So let's go to another example, care delivery redesign. The places who have done CPOE and who've been able to deploy computerized physician hour entry in the inpatient side are very rarely able to demonstrate, are people really using whatever were the best possible evidence-based pathways you put into place? Do you measure them? Do you hold ICUs and units accountable to say, you know, we want to make sure what we put as, now there's a difference between that versus cookbook medicine, but at least on every admission, you should use the best practice standards. And here's an example. This dashboard is available on every unit to every medical director as well as the nurse manager who can take a look at the fact that here's an example over a long period of time on all our admits and all our adult units. You can see to show 98% adherence on every admission to the order sets that we continuously refine on each admission is really remarkable because you really don't see such high adoption. But at the same time, when you go into the comments, because those are captured also, you realize when people deviate from it for the right reasons. So it is really capturing both the quantitative as well as the qualitative path. And then tying that not to barcoding, to take that intelligence from a CPOE into this relation data warehouse, we're able to measure pre and post closed loop. And for the non-physician in the room, what closed loop is linking the physician order entry system to nurse administration to the pharmacy, all in one communication link. Not just CPOE at the front end to get rid of the handwriting errors, is linking the decision support. We were able to show, in terms of adverse drug event reduction, and this is a paper that's gone into publication, that we were able to show post-closed loop this huge reduction in ADEs because of the communication link that got established around complication preparations. The other thing we realized in the care delivery redesign, children are not little adults. Yet every IT system that's sold today on market has to be retrofitted to really, because there's not enough market. So to really be applied to children. And we have a 200-bed children's hospital. So what we did was that we designed our own algorithms. And really, the whole point was, again, when you start looking at IT, it is powerful enough that you don't have to take it the way it is. You can refine it and change it. For example, a 90-pound 4-year-old is very different than a 90-pound 16-year-old. And you've got to understand, and systems can make that calculation for you, that how do you need to dose and drug these patients. And here was an example in our pediatric ICU, similar reduction in ADEs, again using the same supposedly off-the-shelf system, but putting measures around them. What were we trying to affect? We were not just doing CPOE because somebody said to us, you got to do it. We wanted to do it so there was a measurable impact, and we didn't sit still till we really got to it. So by putting the measures in place from pre and post, that could actually be able to be measured in a longitudinal relational way.